I'm going to ask first Dr. Kathleen O'Connell to present the paper on effects of Nissen fundoplication on ablation of Barrett's esophagus with endoscopic endoluminal radiofrequency ablation. Kathleen, welcome. This you go forward?
Okay.
Yeah, and this you got your laser pointer here too.
Laser, yeah. Great, thank you. Okay. Good afternoon, members and guests of the Congress. Today I'm presenting the results of our study looking at long-term maintenance after radiofrequency ablation in Barrett's esophagus patients. We have no disclosures. The objective of this study was to investigate the effectiveness of medical management with proton pump inhibitor therapy versus surgical management with a Nissen fundoplication when combined with radiofrequency ablation in achieving long-term eradication of Barrett's esophagus. We know that chronic exposure of the esophageal mucosa to gastric acid and bile reflux has a synergistic effect in the development of Barrett's esophagus. 10% of patients with gastroesophageal reflux disease develop Barrett's esophagus. These patients are 40 times more likely to develop esophageal adenocarcinoma than the general population. Endoscopic endoluminal radiofrequency ablation is becoming a popular treatment option for the patients with Barrett's esophagus. Several studies have shown effectiveness at various stages of the disease, and long-term ablation has been demonstrated. Importantly, there are minimal side effects associated with this type of ablation. It is believed that decreasing the exposure of esophageal mucosa to acid and bile reflux is necessary to maintain the neosquamous epithelium that is generated after ablation. Usually this is attempted either with proton pump inhibitors or Nissen fundoplication. This is an image of Barrett's esophagus prior to ablation. This is the mucosa immediately following ablation, and this is the neosquamous mucosa at follow-up endoscopy. This study was a retrospective analysis of medical records. Only patients without endoscopic evidence of malignancy and with endoscopic follow-up at 12 months or longer were included in this study. All patients received radiofrequency ablation with the Barrett's device. The patients with fundoplications had surgery either prior to the ablation, concurrently with the ablation, or after the ablation. Patients without surgery were prescribed proton pump inhibitor therapy twice a day. Charts were reviewed for the presence or performance of Nissen fundoplication, the pre-procedure length of Barrett's esophagus, follow-up endoscopy, follow-up biopsy results, and necessary additional ablative treatments. Of the 77 patients treated with radiofrequency ablation, 47 had documented follow-up at 12 months or longer. 19 of the 47 patients had fundoplications, and 28 of the 47 were medically managed. The surgical patients had a median pre-ablation length of 3 centimeters. Likewise, the proton pump inhibitor patients had a median pre-ablation length of 3 centimeters. There was a statistically significant difference in the number of resistant or recurrent cases of Barrett's esophagus between these two groups. Of the 19 surgical patients, 1 had endoscopic evidence of Barrett's esophagus after ablation. Of the 28 medical patients, 7 had endoscopic evidence of Barrett's esophagus after ablation. We also found a statistically significant difference in the median pre-ablation length of Barrett's esophagus between the resistant and the responsive proton pump inhibitor patients. The resistant patients in the medically treated group had an initial median length of 10 centimeters, whereas the responsive patients had an initial median length of 3 centimeters. In conclusion, endoscopic endoluminal radiofrequency ablation with anti-reflux surgery appears to be more effective in maintaining long-term ablation of Barrett's esophagus than radiofrequency ablation with proton pump inhibitor therapy. Additionally, patients with long segment Barrett's esophagus may be at increased risk for recurrent or resistant Barrett's esophagus. When planning radiofrequency ablation for these patients, consideration should be given for anti-reflux surgery. A randomized controlled trial is needed to confirm these findings. Thank you.